Good afternoon, everyone. Welcome back. So this afternoon we're gonna have the Great Bay Area International MedTech Symposium, and as you can see from the list of our permanent speakers, we have distinguished guests from the senior management from the Hospital Authority of Hong Kong, and we have world-leading clinicians from Prince of Wales Hospital, and we have the top-tier engineers, and we have the top-tier MedTech entrepreneurs as well join us this afternoon. So I think this is really a wonderful and a rare opportunity to invite all of these key people in the MedTech area to be together in one session and discuss about the MedTech industry development. So before the official talk of today, I would like to invite Professor C.C. Chen to give us an opening speech. So let me give a brief introduction of Professor C.C. Chen. Professor Chen is the first academician of Chinese Academy of Science of Engineering in Hong Kong. I think it's in 1997 he was elected to be the Chinese academician. And also, he's also a fellow of Royal Academy of Engineering. So it's very fit to today's topic actually, because he himself is a bridge linking United Kingdom and Hong Kong, as this is what we are achieving today. Professor Chen is also the honorary professor at the University of Hong Kong and the founding chairman of International Academician Science and Technology Innovation Center. Besides that, I'm very proud to say he's also the Chief Technology Strategy Advisor of CAIR. So it's my great honor to have Professor Chen to give us today's opening speech for this symposium. Professor Chen.
Thank you so much, Professor Liu, for your kind words. Today, in fact, is a very special occasion, and we have this the establishment of the Hong Kong MedTech Hub, and I hope the establishment of this hub will mobilize all of us, particularly in the Great Bay Area, to push the MedTech technology, okay? So, first of all, thank you, Professor Liu. Yesterday, you treated me very well. Very great dinner. And perhaps you still remember my joke yesterday evening. Okay. So, let us start with that. As you say, I am pleased to be the connector between UK and China, Hong Kong, because during my career, I have been both in these two countries, grow up. So to be more serious, first of all, I think both China and UK are great countries. As you know, China is the oldest civilization in the world. But UK is the first baby in the modernization, because the first industrial revolution happened in UK. Okay? And also, as I know, the first generation of Chinese engineers is trained and educated in UK, because the UK university history is older than American university. So many American universities, for instance, Harvard and MIT. Why there's places called Cambridge? Because it's the Cambridge professor immigrate there. As you know, during those days, in the medical school in United States, the final year must go to UK, Because in the US, only the first and second year. The final year, you must go to UK for internship. So to cut it short, I think both China and UK is great country and contribute to the world civilization. And today, we are entering in the new era, okay? We are entering at a new era. As you know, China would like to start the social modernization, and China will start to entering the second 100 years goal. And UK also, although UK now is not so influenced as before, but UK is still the best in technology. Although UK today influence is not as big as before, but if you look at the origin, the many origin science as technology, it was in UK. You know, I am the Cambridge fellow. I know that in the Cambridge, very simple lab, well, which very simple, but have many Nobel Prize. Because the thinking is the most important, not just the equipment. You know, to be frank, today the Cambridge equipment maybe is not as good as Tsinghua, but so many Nobel Prize there. Innovation is the most important. The way of thinking, holistic thinking, freedom of inquiry. That is the origin of science and technology. Today, we are entering many new challenges, and that I think if we do not, so far we do not against the physical law, everything can be done. Everything can be done, okay? So we must take this good opportunity. Good opportunity we have to strengthen the collaboration between China and UK, particularly use our base. This Great Bay Area is our base. So both, I hope that both the Chinese and British scientists, engineers, investors, entrepreneurs can work together in this region to make our Great Bay Area become one of the most successful. As you know, we have 4 Bay Area now. Number 1 is the San Francisco, the Silicon Valley. I think it's still the best. Then the second one is the New York Bay Area. The third one is Tokyo. The fourth one, we are here. The total area, the total population, the total economy, we are the best, we are the biggest. And the most important that the other don't have, we have 2 systems. We have capitalist system and socialist system. That is what we have. Of course, we still learn a lot from the Silicon Valley, but our prospect and our area is much bigger. It's much bigger than total the 3. So it is very good opportunity for us. So now talking about this Hong Kong MedTech Hub, just talk about the medical. So the number of patients with cranial encephalopathy in China is increasing, and the Chinese government has always strived to provide better medical and health conditions for the people, improve the level of diagnosis and treatment, and reduce the cost of medical treatment. Hong Kong's unique advantage under the constitutional principle one country, 2 systems has established Hong Kong's role as a bridge linking the mainland and the world, and an ideal springboard for foreign businessmen and personnel to enter to the mainland market, helping the nation to bring in and go out. If I quote President Xi, it's 背靠祖国，连同世界。OK， 这是我们特殊的地位和优势啊。So emerging technologies are becoming a new engine for global development and a new topic of global governance. In a science and technology-driven future, healthcare organizations must undergo fundamental change if they are to meet today's global challenges. the global healthcare industry is on the cusp of a major transformation as a range of new technology disrupt the way we deliver and receive care in the first century. Focus on key cooperation areas such as biomedicine, medical care, software information, artificial intelligence, integrated resources. The transformation of achievement is an important link to achieve self-reliance and self-improvement in science and technology and provides important strategic support for it. Today, the Hong Kong MedTech Hub, a joint partnership between the Center of Artificial Intelligence and Robotics, or CAIR, and the King's College London, has been established. The cooperation of CAIR and KCL London in medical technology field can bring hope to more patients and their families, reduce the pain of patients and the burdens of their family, and also provide a broader space for promotion of research and development. The two sides can also explore multi-party cooperation to study possibility combining multiple therapies and jointly contribute to the human health. I fully agree with that. So I think this hub is not just UK and China. By using we as a grip and as a base, it's multiple. It is multiple, and I hope when next time we get again, I can see your achievement. Thank you so much.
Okay, so now let's welcome our first speaker of this afternoon. So we have the great pleasure to have Mr. Kevin Tsai, the Chief Information Officer for Hong Kong Authority Hong Kong Hospital Authority. So welcome, Mr. Tsai.
Okay. Yeah. So it's a remote control, right? Okay. All right. Distinguished guests, Professor, and also good afternoon, everyone. Today I would cover, how Hospital Authority Hong Kong conducted corporate innovation, right? So innovation is difficult in large corporate, particularly in highly regulated healthcare industry. Right, because risk is the top priority to consider. On behalf of my colleagues from Hospital Authority, I would like to share how we conduct corporate, scale innovation. So this is the major summary of our models and the process, right? Since we established our innovation office 6 years ago, through many trial and errors, we gradually built a systematic model, something like this, right? Engaging entire HA staff, we have 90,000 staff, embracing innovations. So on the left of the slide is our innovation vision. It links to our long-term corporate vision, which is, HA's sustainability and the service model transformation. It also caters for short-term needs, such as relieving, HA's operation pressure and the risks. On the top right of the slide is our innovation model. This is, in fact, a very standard innovation funnel. Consists of 4 steps, starting from discovery to proof of concepts, and then pilot. So you can see in HA, we spend a lot of effort in proof of concept before hospital pilot. On the bottom is our HA's own invention. You will see there are 3 blocks there, right? it's a 3 HA-wide organization. The proof of concept organization, consists of 6 technical accelerators, right? The hospital pilot organization consists of 5 digital accelerators, and the formal project organization consists of 4 digital HA programs, right? So next slide, please. In terms of leadership, we invited our CEO to chair the innovation committee. Through 3 levels of innovation organization and the governance, we successfully connected innovation to the formal company project funding and the product delivery process, right? Okay, next slide. Our innovation is not just incubating ideas, but also delivering solutions. Inspiring management practice from airline operation center, we built Greater China's first hospital command center. The hospital is a very, it's a labor-intensive workplace. A large hospital with 2,000 beds often employ 8,000 staff working in highly collaborative model. Starting from proof of concept, we designed and piloted this hospital command center in QE, Queen Elizabeth Hospital, and received amazing efficiency gain as shown below, right? So these are the real results. Actually, we have the senior IT manager here, Wallace here. He is the one in charge of the building this hospital command center. Next slide. The innovation part of this hospital command center is, instead of relying on traditional hospital hierarchy of workforce, we applied digital twin, mapping hospital demand and supply to 3 virtual command centers, then developing real-time resource tracking and AI-based resource modeling to drive smart hospital operation. In this slide, you will see that we have command centers managing 3 domains of hospital management, right? On the left is we call capacity command center, right? And then which really manage the beds, which is the most precious resource in the hospital, and also the resource one managing the staff resource, right, which is our supply. And then on the right, clinical command center is the real-time monitoring of the e-vitals of patients, right? And also, of course, the future is that you can apply many AI predictions, right, to real-time having the alert or alarm, right? And on the bottom, that's some of the key technologies we're applying. Real-time tracking, basically all stretchers, people, patients, important assets, everything will be tracked in real time. And then on the bottom right is we are developing AI models to real time, sense and dispatch those important assets. Right. Okay, next slide. AI is another big area of innovation. Radiologists, are out of supply in Hong Kong, particularly in public hospitals. We developed our own, chest X-ray AI solution and fully deployed to all HA accident and emergency department since 2019. Right. Next slide. This is our AI development roadmap. Right. This is for our internal, but it's okay. You take photo. we have 60+ AI solutions under development or deployment, either in clinical and non-clinical, covering many spectrums of healthcare. Next slide, please. Once innovation prototypes passed proof of concept, we have digital accelerators helping them scale up adoption quickly to more hospitals, right? To ultimately to all 43 hospital, 123 clinics. In 2 years' time, we have developed and rapidly deployed over 20 smart hospital solutions to all 43 hospitals. Okay, next slide. Apart from digital accelerator, there's another buzzword, it's HA's invention, it's called technical accelerator. Our technical accelerators focus on evaluation and the selection of new technologies. Here is a list of of last year's focus, mainly on patient-related smart care, smart hospital support, and management. Okay, next slide. For guests who are interested to collaborate with Hospital Authority Hong Kong, here I listed 3 contact points for your reference, right? Starting from the middle. For clinical innovation, please approach our clinicians. We have 3 doctors here. Clinicians of our hospital directly, right? And then on the top, for non-clinical innovation, actually it's also a very big area. Please approach our, contact our innovation lab, the contact person, everything, QR code here. And then for data and AI collaboration, please contact our data collaboration lab, right on the bottom. Okay, next slide. For innovation lab, please note, I have the email address. You can access. You can register your interest, everything. We offer 4 areas of services. We are the bridge liaise with HA with the innovation ecosystem and the solution supplies. We conduct bi-weekly innovation webinar to the entire HA staff and organize hospital innovation brainstorming in our innovation labs. Apart from this, our key activity is innovation evaluation and proof of concepts. Each year, we benchmark many innovation solutions and a short list for the next step, POC, proof of concept. Next slide, please. Here, I want to give a very quick introduction of HA Data Collaboration Lab. Note the website. We support data and AI research backed by HA's most comprehensive clinical database, covering 8 million citizens, including the deceased and the visitors, for the past 30 years, right? In the past 3 years, we successfully sponsored over 40 large-scale research projects with 8, Hong Kong local universities, with over 200 researchers. Okay, next slide. This is the service offer of HA Data Collaboration Lab. There are 3 levels. The level from the top is a half-day data exploration workshop. We give research a taste using small sample of HA data, right? In the middle, we build a self-service platform with 200,000 patient depersonalized, anonymized data for researchers to prepare for their research hypothesis and proposals. And on the bottom, finally, each year, we support up to 15 collaborative research projects, 12 months long projects, right? By providing 30 years of anonymized clinical data and assistance of our IT and health informatics. Next slide. In the past few years, we have extended our research to most of Hong Kong local institutes and universities. Now, we're exploring collaboration with commercial companies and startups, and of course, to our future partners in GBA. Right. Next slide. We also participate in many local and international communities, innovation communities, have joined project and researchers, right? But however, compare to our dream, this is still too small, right? I think 2023 we will further extend our reach to outside. Okay, next slide. I think that's my last slide. People ask me, are you happy with your corporate innovation? My answer is not yet, as we have bigger dreams. The challenge is that there are many constraints for us to establish strategic partnership with innovation leaders in the ecosystem. And we are seriously lack of dedicated innovation funding and a dedicated innovation manpower. In the end, I welcome you to pay a visit to our innovation lab and AR lab in Kowloon Bay, right? The contact is on slides 10 before. And I'm looking forward to explore partnership with you. Thank you.
Thank you very much, Mr. Tsai. due to the time constraint, we're gonna having the Q&A during coffee break. So if you have any question for Kevin, please grab him during the coffee break. So it's my great pleasure to introduce our next speaker, Professor Philip Chiu. Professor Chiu is the Associate Dean of Faculty of Medicine from CUHK, and he is also the Director for Multi-Skill Medical Robotics Center, also in Science Park. So, Professor Chiu.
Okay, thank you so much. Good afternoon, ladies and gentlemen. So it's my great honor to join this wonderful meeting. I'm a surgeon by training from Chinese University of Hong Kong, and my topic is about development of robotic surgical system for clinical application from laparoscopic to endoscopic surgery. So next, these are my disclosure. Next. Okay, so I always like to show this slide, but this is a coincidence. Then this is actually a slide picture that I took from St. Thomas Hospital Old Operating Theatre Museum. I visited 5 years ago when I brought my son to UK for study. So we were just by, luck that we visited over there. And I always amazed that 200 years ago, this is what the surgeon is working in an operating theatre. So there may be a joke saying that a surgeon is always pretending because we are working in a theatre. But looking at that, you know how primitive it is for surgery to be done with this kind of primitive operative theatre, that we need a real innovation. Innovation always starts from operating theatre. Next. Okay, next slide. Yeah, so the innovation that moved surgery towards the last century include transfusion, anesthesia, antiseptic principle, antibiotics. Without those technology, you can not survive from a surgery. You cannot. We cut open patient. Next slide. Okay, so now when you look into the global perspective, then these are the commonest cancer around the world listed, and most of this cancer is actually treated by minimal invasive surgery. So the minimal invasive surgery concept come from the, I would say last century, end of the last century, where we wanted to be less barbaric in cutting up patient. Next. So I have to say that I'm proud to be Department of Surgery CUHK staff, because our mentor, Professor Sidney Zhong, Professor Joseph Lau, and also Professor Arthur Lee introduced minimal invasive surgery to Hong Kong in the 1990s. The photo that was shown in the right side is actually Professor Zhong with me and the patient that received the first laparoscopic cholecystectomy in Hong Kong, coming back 25 years later, playing with the simulator for laparoscopic cholecystectomy. Next. And we actually convert the past concept of a big surgeon, big wound, next, into a smart surgeon, small wound. So that is totally because of technological advance. Next. And what are the technology that bring us to here, including the imaging, the instrument, the ports. If you don't have those instruments, you cannot operate with keyhole over the patient's abdomen, thorax, or other parts. Next. But then when you look into technological development and innovation, then in this century, I can say that robotic technology is one of the most key important technology that will bring surgery to the next level. Yes, and next. So the Da Vinci robot, as you all know, has been developed for almost more than 20 years. So we are actually the first to introduce robot to Hong Kong and Asia back in the year 2005. And we started operating with the Da Vinci robot. That was the first prototype, the first type, and then we have the Da Vinci S. Now we are working with the XI. You can see the technological advance, including the improvement in the image to 3D and HD, to expanded instrument portfolio. Next. To me, at this very moment, the imaging is our eyes. So the robot is an extension of our hands, arms and hands and finger. Okay. So we are still keeping ourselves as the brain to drive everything. But maybe in the future, the brain will be assisted by AI. I truly believe. So, but then still we probably couldn't replace this pilot because of a lot of understanding issue like medical legal issue. Next. So, but I'd like to introduce the milestone that we have developed at the CUHK about robotics. I think especially when Professor Samuel Au, my co-director of the MRC, is here. So both surgeon and also engineer has been working very hard in this arena to bring robotic technology all the way to clinical application. Next. So what would be the benefit of a robotic surgery? I think for the surgeon, there's big benefit, okay? Because our ergonomics of working will be much better. And also, we can perform really complex tasks with a robotic-driven instrument that allow us to have a better and more precise dissection. For the hospital, it might be a technological advancement, but then, of course, I understand that the technology is really expensive. So some of the hospital administration may also consider about the cost-effective issue. So that may be one of the major issues for introducing robotic surgery to a hospital. While for the patient, they benefit all from the advancement of the technology, and we can do minimal invasive surgery through robotics in a much better manner. So one of the key examples is probably the robotic prostatectomy. It's even better than doing a laparoscopic prostatectomy in terms of less blood loss and a shorter operative time. So next. So this is one of my procedure of doing a robotic assist esophagectomy. So I'm an upper GI surgeon. I do esophagectomy. Next. So maybe this kind of operation will be too barbaric and bloody maybe 30 years ago to show on a video. But right now, I think this is a really modernized way of doing a esophagectomy. So with the robot, we can perform precise dissection. So treating cancer is not only taking away the organ, taking away the cancer, the organ, and also the surrounding lymph node, which are important area that may harbor the cancer cell. So you have to be really precise. Like in this dissection over here, there are important nerve, and also I'm dissecting around the subclavian artery. Okay, if I damage the artery over there, major bleeding. If I damage the nerve over there, you lost your voice. So we have to be really precise in dissection. So the robot actually allow us to do so. Okay, so this may be a kind of outcome that may not be countable because eventually the patient will recover. If you use the hard fact of blood loss, pain, it might be similar because we are just using the same small keyhole. Compare laparoscopic versus robotic. But we know the quality of surgical dissection is much better with the robot. I think these are the advantage. Okay, next. So how would the future be for robot? Could that be the image that you wanted to see? Exactly like no man inside? Maybe not, but this probably will represent some of the future technology that we can introduce to the operating theater. Next. So one of the, well, I probably do not have the crystal ball, but I would gather that most of the people do not like even the kind of surgery that I described, to resect your esophagus to treat your esophageal cancer. Because if you can preserve your esophagus, that would be ideal. That depends not on our skill, not on our diagnosis. It depends on the stage of the cancer. We surgeons are really a bystander to management because the diagnosis of a disease depends on when you recognize it. This doesn't depends on how best we are as a surgeon. So if you treat these kind of cancer, then you need the esophagectomy. But if you treat those cancer like on the right side, it's an early stage, you don't need to resect the esophagus. You just need to resect the mucosa of the esophagus. Next. So I would predict in the next 5 to 10 years' time, there will be much more this kind of early cancer being diagnosed. So my argument will be including the application of new technology to diagnostic tool like endoscopy with the AI we can have a better quality control for the endoscopy. We have a better AI-assisted diagnosis for this early lesion. Secondly, I think probably everybody know Professor Dennis Low, our outstanding scientist at our faculty who are doing the non-invasive prenatal diagnosis, and his technology is going to apply to cancer diagnosis. If you can have take a blood and diagnose to have early cancer, and the third technology, of course, is a government which is pushing towards screening program for all this cancer, then the only result of this strategy will be more patients will be diagnosed as an early disease. Okay, next. Then there will be increasing potential for endoscopic treatment because early stage cancer do not need to take away the organ nor the lymph node. It only need to take away the mucosa that harbor the cancer. Next. Okay, so well, I'm the first one to actually do this procedure in Hong Kong, which is called the endoscopic submucosal dissection. It is actually a mucosal treatment for early GI cancer. We just perform the dissection by using the endoscope that passes through your natural orifice, either your mouth or your anus. And then you can go into the deep inside the GI tract and resect this cancer. We now are assisted by the best imaging. You can see these are the HD image from endoscopy. It's very clear. But the only problem is that we are only operating with one hand. So there's only one instrument dissecting, which is over that, like a 7 o'clock position. Otherwise, you need to manipulate the endoscope to take turn and do the dissection. That is really clumsy. Next. So this is probably a good photo to demonstrate how clumsy this is, to attach your knife to your forehead and making the dissection. Okay? This is what we are doing now. Moving your head with the knife. So imagine how you eat like this. So that requires us to have a really good skill. This technology is being developed in Japan. So you understand Japanese samurai, they have really good skill. They are really trained for doing one thing. But other surgeons, other endoscopists cannot do the same. Next. So we need a better technology. So one of the endoscopic technology that we developed together with Singapore is in fact an endoscopic robot. It's called the Master-Slave Transluminal Endoscopic Robot, pioneered by Professor Lawrence Ho from National University Singapore and Louis Free from Nanyang Technological University. The idea is like that. Actually, when my mentor, Professor Sidney Zhong, visited Singapore, he enjoyed the chili crab of Singapore, and then he wrote this on a paper, and that developed this system. Next. We actually bring this system to clinical trial in Hong Kong back in the year 2011. So it's a really, really primitive prototype. If you have watched the movie Iron Man, this is Mark I Iron Man. It's only enough for you to escape, okay? So that is university level technology. But then with this primitive technology, we actually performed 5 cases of ESD, 2 in Hong Kong, 3 in India, as a proof of concept study. And of course, this was the history. And but then the technology actually moved forward. Next. We know that we need the team need a startup company to move this forward. So in Singapore, they actually developed a startup company called the EndoMaster to redesign the whole system. Next. So this is one of the preclinical animal trial. I will have to stress that preclinical partnership with clinician, as you mentioned, is so important that you need a tissue and preclinical animal model and cadaveric model to test drive your technology. If you don't do that, actually you don't know the constraint within the human body. So we have test drive this for many times in Singapore. Next. And with that, we actually started the clinical trial for application of this technology EndoMaster in the year 2020. Next. And this is one of my procedure of treating a colorectal early cancer with this EndoMaster. So this is a almost like 4 centimeter lesion. It's not a small lesion. It's located in the rectum, but our technology can actually bring all the way to the cecum. It's a little bit thick endoscope, but it by some manipulation, it can reach the cecum. But this is applied to treating a rectal lesion. And after some mucosal injection, then we use the two robot arm that comes up from the 6 o'clock and also the 9 o'clock position. And then we actually do some calibration afterwards. We will do the dissection. So it is like two arm. So now with not like a knife attaching to the forehead, but using the two arm, we can perform the submucosal dissection in, first of all, with the mucosal incision, and afterwards using the left arm to hold up the mucosa and then perform the dissection. So of course, this is a technology that is pretty new, but at the same time, I think we have hopefully, continue the development and hopefully to downsize this system. But we have actually conducted this trial at the Prince of Wales Hospital for 43 patients, okay? And it's proven to be safe and effective in all these patients without any technological error. Next. So in the Chinese U, we also are developing our own robotic system, and that will be partnered with the existing platform. Next. So this is our development of a platform. We focus on just the two arm. We are partnering with the USGI using their transport to do the same concept. Next. Yeah, and this is a preclinical animal study. Next. And same concept, the two arm, one for lifting, the other for dissection. And the endoscope is also definitely important as our eyes. So same concept for surgery, but putting it to the endoscopic level. So next, because of time, I need to rush. So anyway, so this is the latest development of our system. Next. And but then as a surgeon, I think the future, not the next 5 years, but maybe the next 10 to 20 years, is probably rising into a more smaller scale robotic surgery, like millimeter or nanoscale. Next. So we are working with, again, another team of engineer who is focusing on nanotechnology. So imagine that there might be a disease inside the liver or the bile duct. So currently we have endoscopic technology that can cannulate into the bile duct for treatment, but we can only reach maybe the second generation of the bile duct and not beyond. But imagine that through the endoscope, we deliver the nano robot that can have a drug delivery ability or stem cell delivery ability that can pass through the bile duct, entering through the ampulla of Rata into the bile duct all the way up to the third or fourth generation of the bile duct. So then by guidance, there must be image guidance because we cannot look at it, but we have already tested a model of using ultrasound that can actually image these nanorobot. And we have endoscopic ultrasound. So through the endoscope, we can monitor, and using a magnetic guidance, we can move this magnetic robot inside the bile duct for target treatment. So that will probably be the future. Next. So with that, actually, we are really, really honored, Samuel and I, being successfully applied as one of the HK Center called the Multiscale Medical Robotics Center. And it's one of the 4 Center from CU Medicine that were granted. But of course, this is a half medicine, half engineer center. Next. Our concept is simple. It's to translate basic engineering technology to clinical application. So that's why you can see engineer and clinician working together in this center. And of course, I think Professor Liu, Dr. Liu and his team already enjoyed our center because we are in close collaboration that your cadaveric model trial for the neurosurgical robot, where Danny and you lead, have been, we welcome you to test drive there at the cadaveric model. Yeah, next. And we are equipped with all these instruments, including the Seagull 3D CT and also the MRI machine that are aligned in the same alignment. So this is, again, a test drive platform for preclinical. So you can't actually find this instrument outside the hospital in, maybe in Asia. This is the only center in the world, probably one of the 3 centers that allow you to do repeatedly preclinical cadaveric and animal trial using this technology combined with the robot. So next. And I think we also have the advantage because when we are having the location, you can see that CUHK campus, Science Park, Prince of Wales Hospital, and our CU Medical Center are within 15 minutes drive. So that is a big advantage. Surgeons like me and Danny need to work in our OR. But in the afternoon, after we finish the operation, we can come to here and test drive. We go back and see our patient. So this is so important. And the engineer, in a vice versa way, if they need to improve the technology, they can go back to center and come back to the Prince of Wales Hospital for clinical trial in supporting the trial. So I think a similar concept as, of course, the King's probably better because you're located within the hospital. But it's difficult to find a place here in Hong Kong to locate that in the hospital. But I think we are close enough. Next. So I think the second last slide, I believe that the future of surgery, greatly enhanced by AI and robotics, I can see semi-automation or AI-guided surgical procedure being a good, friendly development manner to us as a surgeon. So next. And I do believe that we cannot solve our problems with the same thinking we use when we create them from Albert Einstein. Thank you very much.
Thank you, Professor Chu, for your very inspiring talk, and thank you for your support of, and thank you for the MRC support to the project Dan and I are going around. It's certainly very, very helpful. So our next speaker, I would like to introduce our next speaker, Professor Danny Daming Chen, the consultant in the Division of Neurosurgery in Prince of Wales Hospital, and also the Associate Director of CUHK Otto Wang Brain Tumor Center. Danny.
Thank you. Thank you, Hong-Ben, and thank you, everyone. It's my great honor to be invited to speak here. I just heard about innovation from Professor Chen and Mr. Chai. And to let innovation translate, I think one more thing that I want to talk about is collaboration. Okay, I'm not inventing the word surgeon nearing. Okay, now you can Google this word, which is the collaboration between surgeon and engineer here. Okay, so I'm going to share my experience how we work with the engineer. That I have 3 projects undergoing, which is very pleasant collaboration. 3 robots you can take, which with engineer, and all of them are going to translate to patient care to enhance safety. Next. So the first project is I pump in the Professor Kwok from Hong Kong University, okay, about 8 years ago, and then we envisioned to make an intra MRI DBS robot, okay, because I do DBS while Professor Kwok is doing MRI engineering, which is becoming more and more popular, which I expect in maybe next round that this technique will be granted the Nobel Prize, I think, which is kind of helping a lot of Parkinson patients. Next one, a lot of animation. Now, most of surgery performed in awake surgery, okay? Now, why MRI is good? Because MRI look at the brain very nicely, okay? We need MRI to target, okay, for DBS. Next slide. And Professor Kwok showed me now the MRI technique is so fast, okay? We can real-time scan the heart beating, okay, let alone the brain localization. Now, in fact, now we have the clear point, which is system approved it for MRI, intra MRI guided DBS insertion, okay? But you can see it's still very cumbersome. The surgeons like tele kind of long distance controlling the navigation or the localization. What our vision is, how about if we replace the surgeon with a robot? Next. We have some intra MRI robot, but all of them are too big for our DBS. So we have some challenge if you want to do it, okay, about MRI safety, how to fix, the robot in a small footprint of the scalp, okay, and my requirement to Professor Kwok will be, I need a bilateral robot, okay, to cut the surgery time half. Next. So fluid, okay, the water will be the solution that to MRI compatible driving the robot. So his suggestion is we should have a hydraulic, low friction hydraulic transmission robot that he's making. Next. So small footprint, okay, just one anchor in the scalp, and then we'll be operating at the same time for two sides. Next. And the best thing that I like is he's suggesting we should have additional tracking, intra-MRI tracking system, okay, to confirm the localization is accurate, because our degree of precision is down to 1 millimeter. So next, there's an animation next, okay. Next, yeah. So we are able to do a cadaveric trial, okay, and which we come down to the degree of accuracy of within 2 millimeter, 1.73. Next. Next. Next slide. Is it moving? Oh, what happened? It happened, yeah? Proper crash. Oh. Should I be using my laptop? And what I mean is that the engineer have accomplished all my demand, okay? Small footprint, bilateral, okay? Intra-MRI manipulation. So the surgeons only need to do one actuation, is to puncture, okay? To put in the electrode. Now the whole workflow improves the safety, okay? Because you can imagine just the clear point, you will need the patient come out and in of the scanner many times, okay, which will increase the error of the position. While with within the bore, the robot can do everything. Just one puncture come out, and then it will, in terms of workflow, if you can have a next slide, it eliminate a lot of error from this surgery. Next slide, can you do? Yes, yes. Now the usual workflow is like this, okay? All this thing will be increasing the error, okay? If with the robot, okay, next, we eliminate all this error, okay? That will increase your precision and safety. Next. So this is our prototype, okay? So I just need to do one puncture, and that's it. And it's cut the time. So the robot is very compact, okay? Next. And with MRI compatible actuation, and also I like this tracking system, which is on top of our real-time MRI localization. Next. And so it was sent for a competition in the IQA 2018, and very fortunately we're given the best paper award during that year. The next. And we publish in a clinical journal some paper, and also now we are on the second stage of receiving the ITF grant for the second stage of trial. So next. So next project, which I work with my colleague here in the CHK, Li Zheng, Professor Li, about a biopsy. Okay, we start as a collaboration. I like very soft collaboration, means it's not. So I try to invite Professor Chiu, and I think Sam as well, to a popcorn meeting, which is a Friday evening after work, okay? So with popcorn and with drink, and the engineer and the surgeon come together to talk, okay? There's no agenda, okay? Just talk what you're doing. Okay, next. So it's everyone here for a popcorn meeting, and they spin out a lot of things. Next. This is the paper which after the meeting I draw down, okay? And then next. Okay, this is the project that through the paper that we work on next. It's about biopsy, okay? So now we do biopsy just by handheld, okay, manual experience of surgeon. But we do not know the pressure, the aspiration pressure. How about the safety? Okay, nobody is working on this. Next. So Professor Zhang is here, okay. So suggest to me, okay, how about I make a robot for you, okay, for this actuation, just aspirating brain tissue out. Next. Now, because if it's too much pressure, that you will have a risk of hemorrhage, okay? So brain hemorrhage is very serious. If it's too less pressure, you will yield nothing, okay? Next. So what is the optimum pressure that we don't know, even in the literature? There's no human trial yet. Okay, next. So this is the engineer part, okay, so making a smart robot for me to aspirate the brain. Okay, next. So we try, okay, in the pig brain, go to the market, buy a pig brain, okay, and then try it on, which show us, so this is physics, okay, pressure driven. Next. And so we're luckily awarded the ITF, okay, to start on the first phase of kind of development. Next. And which Professor Lee have added on something else about a robotic navigation guidance. Next. And I was asked to ITF interview, okay? But Professor Lee was not in Hong Kong, so I was the only clinician facing the board of engineer. But I was given $1 million question by the chairman. Is the second, is there any way to predict the pressure pre-op? Okay, this is very stimulating and inspired me to think of something I'll add on thing. Next. Next. So we start the, this is about how to predict, okay? And I find out there's already technology now in trop using ultrasound to look at the elastography, okay, the stiffness of the tissue. Then I can predict at what range of pressure that we know. So spin off another human trial on it. Okay, next. So this is the physics, okay, the elastography, how we give the force and the deform, the formula, how it deform and predict the stiffness in the brain and the liver. Next. And in fact, it's applied to clinical neurosurgery already at that time. Next. So this is our setup, very simple, okay? Same as my surgery, except I have a T extension to measure the pressure. Next. Next. So this is the elastography, real time, that I can, through the color code, I can predict the tumor is stiffer or softer. Yeah. Next. Next. Okay, this is how to analyze it. So there's a video showing how we do it. This is the aspiration that I do. Previously only by manual, by experience. Now I measure the pressure. Next. This is a long video. Maybe we start at the middle of it. Maybe go to the middle. This is what Professor Lee made for, okay, yes, this one. So the final product is, I really like because it's doing the actuation of puncture and also aspiration, and also with good precision. Yeah, look at it. So the trajectory, okay, puncture. And there should be one more actuation is puncture and then aspiration and then even take it out as the surgeon's maneuver. So we do not want to change the design of the cannula. So to make it versatile. So insertion and then look at here. And then we'll have the aspiration from here. And I did a lock, okay? I did a lock, okay, the tissue. So I like this robot. Okay, very good tissue we can get. Next. Maybe we can skip this one. Okay, next one. No, next slide. I mean, this is repeating the video. Next slide. Yeah, okay. And same, we publish it, and luckily we are awarded of a bronze prize. Okay, next. Next slide. Okay, next slide is the collaboration with Hong Ben Liu, okay, which I have posted out this one hole killing two birds request, okay, internationally in one of the conference organized by Philip, and which is in 2018. Okay, I wait because nobody responds to me. Okay, okay. So what's the clinical demand or question is? We have a clinical problem called germ cell tumor, which we find out Hong Kong Chinese get the highest incidence among the world. And they all happen in young patient. Okay, next. Okay, very young kid. Okay, children. Next. We compare with Japanese and the US, we are the highest in incident. And this is a tumor. Okay, we call it at the pineal region, very deep brain at the back of it. Okay, what we need to do next. We need to do a biopsy and a puncture to cure the hydrocephalus. So-called, we call a fat ventriculostomy, and then turn around. Okay, next. To a biopsy. Okay, but we are using a rigid scope. Okay, so the turning around here will be a danger. Next, because there is a structure we call this a hole, the foramen Monroe. Next slide. Next, yeah, because this is a fornix. This is the membrane fiber. Okay, it was next to the Monroe. Next. Okay, so our scope pass through here. If you turn around, okay, that would be a risk of injuring this and then causing the membrane deficit. Next. Yeah, it's a very small kind of foramen. Next. Now, if I can turn around, then I can treat, because all the patients present the same way. This is my collection of patients. All the patients present with the same way, with hydrocephalus, a tumor at the back of the brain. Okay, next. Now, there are several options here. A, okay, will be rigid scope. Okay, then you're risking injuring the fiber fornix. B will be you will need two track. Okay, for it. Okay, next. Fornix injury, two puncture. So we think the best way will be the third one, that a turnaround with a flexible scope. Now, do we have a flexible scope? Yes, there's one flexible scope. Okay, but it is not that good. Next. Okay. The effective length is 7 centimeter. So our third ventricle is much less than. It's only maybe 2 or 3 centimeter. Next. So what I need, my request to Professor Liu will be tip bending, defectively within 50 millimeter, okay, to an angle of maybe 40 to 60. And the best if we can have a VR control for safety. They can look at the back. Okay, next. So I met this guy, okay, after he met the queen. And what he replied to me is, Danny, I can do it for you. Okay, next. Then we start the collaboration. So he's showing me his flexible scope, okay, a very small one, okay, 4 millimeter, okay, very bright, okay, next. I want to show you the real. And then I love to collaborate with Hangbin because they are very fast, okay? Within 6 months, we developed the scope, okay? Next. Okay, I like this virtual reality as well, okay, because I don't have it clinically. Next, I want to show you the real video. We are testing on the cadaver for this one. Okay, next one. Next video, maybe. So we're testing. Next, okay, there should be one confidential video from next. This one, okay, I want to show you. Now this is our final design. Okay, there's a forward camera and there's a backward camera here, which I request for safety looking at the Monroe. Okay, we're not hitting on the Monroe. Okay, now this is parallel. There will be this is parallel with, there should be one more view, okay, about my actual real patient video. Now we are passing through into the third ventricle. This is my real patient video, okay? The same, okay, what we are observing in the cadaver and in the real patient. So we can see the third ventricle floor. We need to make a hole over here, and our robot do the same. And I like this camera observer view that we have not moved the Monroe a bit, okay? So we can observe clearly, even for the cadaver, the third ventricle anatomy. So in parallel, we are doing the same thing. So we can puncture it. Here we puncture it. Downstairs there's a vessel, a basilar artery that we must not injure, okay? If we injure it, the patient dies. Now, but after puncture, we need to look at make sure we have go down in until we see the basilar artery. In real life, we have a small balloon to bring it up to make sure the opening is adequate. So in real life, you can see there should be a vessel pumping. In the cadaver, we can see the same. I think this is the first time show to outside, right? So you can see this is the vessel, okay? We can see it from the cadaver as well. A little bit difficult because cadaver is not as nice as. Yes, you can see the basilar artery over there. Now the key is here. You turn around now. We're waiting to going back to the back to look at the tumor. Okay, of course cadaver do not have a tumor there. So we go to the pineal region. Okay, now is turning around the scope. Now it's turning around. Okay, you can see it turning around to the back of the floor, and then you will see the back of it. Now, in real surgery, I need to turn the scope backward. Okay, that is a very risky maneuver that may injure the Monroe, the fornix. Now here we can see clearly the pineal region. The pineal region is over here. The aqueduct is the area passing through to the brainstem, to the fourth ventricle. And we can see almost exactly the same thing that now we are seeing. Now I think next, okay, we can skip the rest of it. Okay, so and more than that, okay, our ambition is to make ventricular surgery fully robotized. Okay, now we do not have these flexible things to go around. The rigid thing have all the shortcoming from Phillips have mentioned. Next. Very luckily again, okay, we are awarded the Bank of China Technology, Science and Technology Award a few months ago, but the mission is not accomplished yet. Okay, just a prototype. Next. How it translate to clinical is, I think, is safety. Okay, for us, those who are in the clinical sector, that human factor and the Murphy's law is something that we cannot avoid. Okay, no matter how low the risk, okay, it would happen as long as there's human. So my philosophy will be next, remove the human factor. Next, by machine. Okay, I think this is our vision. Okay, that will bring safety. Okay, next. And I think machine is safer. Okay, this is all I want to talk about. Thank you.
So our next speaker is Professor Xi Ning, Chair Professor of Robotics and Automation and the Head of a Department at University of Hong Kong. Professor Xi is also the Director of Advanced Technology Institution, from Department of Industry and Manufacturing System Engineering. Because Professor Xi has an emergency meeting today, so he pre-recorded his talk.
Good afternoon. So it's my to be here. So basically, we're talking about how the wearable robot can help us to face the grand challenge of the society, the aging problem. Okay, we know rapid aging is one of the grand challenges, right? By 2030, right, 1/4 of the Hong Kong people will be over 65 years old. Okay, so there are many reasons, because one of the, it actually is a good thing, right? Because our lifespan gets longer because of technology, medical service, or the living condition and the environment. Okay, but in another side, there are a lot of older people in the society, right? That cause some problems, right? Because older people usually they have like a mobility problem, manipulability problem, health problem, right? So how to provide the elder people with a healthy aging, and at the same time provide them with opportunity to make a contribution to the society. I think that is a very important, okay? But the problem, the aging is one of the biggest issue is the mobility and the manipulability problem. The elderly, one of the problems they're facing is a rapid losing of their muscle, okay? But when you over like 40, every year in average, 5% of your muscle will be gone, okay? So if you don't keep exercise, don't like pay attention to the nutrition, the process will be faster, okay? So this kind of problem called the sarcopenia, okay? But once you lose a lot of muscle, right, then you get weaker, right? Then you will have a mobility problem and the manipulability problem, okay? That will like create a lot of difficulties in your daily life, okay? See the CDC, the US government agency about the disease control, right? They did a study, okay, for the people over 65, 1/3 of them had a problem of falling, okay? Because they have a weak muscle, right? They cannot support the body properly, right? They fall, okay? So that means that 3 elderly over 65, they had experience falling. Okay, then among them, 1/3 of them, right, had a severe damage, right? Like a bone fracture, damage to their head, right? Some of them became permanent, right? Some elderly, once they fall, they break their bone, then they never recover, okay? So all those kind of problems, right, are facing the elderly people, okay? Then the question is, how can we develop technology to help them, right? To help them to improve their mobility and manipulability, okay? So we believe wearable robot can be one of the solutions, okay? Actually, for last 20, 30 years, people have been developed this kind of technology. So you can see these are some of them assistive robot, right? Some called the exoskeleton. So basically you wear the robot, right? Robot will help you to move your leg and move your hand in order to provide a certain mobility and manipulability, okay? But you can see those kind of robot usually very bulky, right? Has a rigid structure, okay? And but recently, people also introduced the technology called soft robot, okay, in order to improve the wearability, because then basically the structure of robot is not rigid, right? Made of the fabric, all those kind of things, so you can wear it more comfortably. But this kind of device, most of them use for rehab, okay, because you have a very bulky driving system, like battery, all those kind of things, right? So it's very difficult to carry it on, right? To use it daily, okay? So then, we can look at the existing system, this kind of assistive robot, actually in the 2 different streams, right? One, we talk about those exoskeletons, that's for performance enhancement, okay? Not for the elderly, even for young people, you wear it, right? You can increase your like a capability, you can carry more heavy load, and you can like jump higher, all those kind of things, right? For enhanced performance, okay? But then in another end of extreme, right? For the like parallel people, right? So those people, they completely lost their mobility, cannot move at all, right? Then they use robot to replace their original mobility, okay? So basically you can think that that's just like a car, human look car, right, to carry those parallel people around, okay? But we are talking about the assisted device is something in between, okay? Because for those elderly, even they lost significant amount of muscle, they still have some muscle left, okay? So then they don't want the robot to replace their muscle. They want the robot to help their muscle, right? But not enhance their original capability, right? But to assist them to recover, right? Regain their mobility. Okay, so that's why it's something in between. This is very important, okay? Because the reason is the muscle, right? If you use some devices, right, to replace muscle, without using the muscle will be gone faster, okay? That's why exercise is very important. So we want the robot to help the muscle to regain some capability, but at the same time, you still be able to use the original muscle. So this way is very helpful to slow down the sarcopenian process, okay? So then from here, you can understand, actually, performance assistance is very difficult, right? One of the reasons is for each person, the amount of sarcopenia, the amount of muscle loss is different, okay? So the solution will be personalized, right? So each person will have a different need. So before we give them the robot to help them, we have to exactly identify what's needed, right? We need a personalized solution. Second is, has to be precise, okay? As I said, the robot will assist muscle, not replace, okay? If you overdo it, the muscle will lose faster, okay? But if you underdo it, right, you will not be able to help him enough, right? So you have to find the right amount, has to be very precise. So that's why this is a very challenging problem, okay? So that's challenge we're facing. So from here, you can see, right, in order to solve this problem, we have to develop a wearable robot, which is precise and personalized, okay? So in order to do this, we develop so-called the UC3 approach, user-centric co-creation. Okay, so key is answer that two challenges, precise and personalized. Okay, see, we first we have to identify where the problem is, right? Because human, like mobility, manipulability, come with 3 different levels. First is like a behavior level, right? So when people doing daily life, right? You walk, you run, you pick up things, you like open the jar, so put the clothes on. So those are behavior-based. But in order to perform those kind of behavior, you need a certain function. Your joint has to move in a certain angle, right? Your arm has to have a certain force, right? So those function capabilities support those behavior. Okay. Then the next level is in order to gain those, in order to have those functions, you need a muscle, right? So muscle move your bone to generate to generate those functions. So those we call the physiological level. So all the activity, all the behavior human have, right? So generated by these 3 levels. Okay, see traditional way, so you can see even like performance enhancement or performance replacement, they are concentrated on what? Behavior level, right? You want to move for the handicapped person, you cannot, right? I give you a robot to carry you around, right? So this is a behavior-based approach, right? But this kind of problem is, like I said, right, cannot help you, right, exercise your muscle, right? Cannot only work for the parallel person, right? For elderly, will not. Then the function level, right? You can put the robot on your knee to move your joint angle to make it work. But the problem is much more difficult because think about it. Our every joint is not have a fixed axis. When I turn my arm, the axis actually is changing. It's not like a motor. When motor turns, the axis is always at a fixed direction, right? Then people say, oh, you can now move your arm. I put the motor there, I'll help you. But while it helps, it forces your arm joint to rotate it around a fixed axis. Actually, that will damage your joint. Okay, so that's why the function level or behavior level will not fully compensate, will not fully provide the necessary assistance to the elderly. We have to go down to the physiological level. We have to find out which muscle is weak, how much compensation we need to provide. So this way we use the muscle to move the joint, eventually improve the performance, right? So that's the approach we're going to take. But from here, you can see in order to do this, first we have to identify where is that weak muscle, right? So how to model that, then how to determine the proper amount of compensation which is needed. Okay, so all of this is built on like a diagnostic or testing and evaluation. Okay, so before we do that, so actually we conduct, right, large number of subject testing in Hong Kong. So far, we already test over 150 people, elderly. Okay, we have certain criteria. We test them what kind of performance level, what kind of deficiency they have. So what's the functional level deficiency? What is the physiological level deficiency? Okay, by understanding that, then we can build a model to tell us how to compensate those muscles. Okay, so for each elderly, we actually conduct 25 tests. Okay, it's very thorough. So the whole test over like 4 hours. Okay, so through this test, we can find out where the problem is. Okay, so once we do that, right, then we can develop a model, compensation model, right, which will tell us which individual piece of muscle need what kind of assistance. Then we develop a robot, right, to help that muscle, right? From here, you can see the key is once we understand where the problem is, the next thing is we want to develop robot, not help joint, not help the movement, help muscle. Okay, so that is the key. We want to compensate at the physiological level. But our idea is we use artificial muscle because that structure very similar to the human muscle. We actually put together with the human muscle, okay, but still use your own control system to control it, okay? So this way we call it a proprioceptive control, okay? So since the robot has actuator, has a sensor, but that will integrate with the muscle sensor and the muscle actuator, but controlled by the same control system as human muscle. Okay, so this way is much more easy to control, to achieve coordinated operation between your own muscle and the robot. Okay, so then at the end, I want to say, see this project I'm talking about is the result of cooperation of multiple people. So we try to work together, right? Try to provide a technology solution to help society, help elderly, eventually help everybody. Okay, then thank you very much. So,
Okay.
我们的心脏在小孩子发育的时候，因为各种原因导致了有一些缺损吧。我们做的产品就是把这个缺损堵掉，是用介入的方法。原来的方法是用传统的，比如开刀这种，可能小孩子，就大部分是小孩的这种疾病吧。那这种疾病的话，对小孩来讲，你要一个外科手术，他可能承受不了。另外的话，一块比较大的业务就是我们的外周血管。外周血管就是是主动脉的，可能有各种各样的疾病，我们更多的集中在一个主动脉瘤，还有主动脉的夹层。我们是做支架。另外的话，还有我们最近几年新的业务吧，是预防中风的 PFO， 也是在心脏上一个缺口，导致可能会这些血栓到达我们脑部，导致中风的。然后还有一个左心耳封堵器，也是最近几年也是比较热、比较火的一个技术吧。左心耳封堵器的话呢，是防止，这是对老年人的，这个市场会更大一些。中国的话有1000万的这样的一个病人吧。然后还有就是这个技术是和美敦力合作的，大家都了解这个行业都知道，美敦力是这个行业top one 吧，是全世界的 top one。这个公司他们的技术，但是是我们的品牌，是那个心率管理的，就是起搏器。然后未来的还有一些业务，当然这个业务的可能很快，我们现在完成了3期临床试验的入组，是基于这个铁基的可吸收材料做的一些产品，走得比较快的，像我们的冠脉支架、冠心病 coronary stent。这个产品的话，已经完成了3期临床的一个入组吧。未来的话，还有其他的新的业务，呼吸，就是说呼吸系统的，像我们肺部各种各样的病，比如说肺癌，比如说哮喘，比如说 COPD， 这些疾病的话，我们也是尝试的用我们这种介入方法去治疗。这个我们应该是一个公司来执行的，就是公司叫先进呼吸。这个公司的话，走得最快的一个产品是在中国正在临床入组吧。另外的话，谈到机器人，其实我们公司也是想尝试用机器人，就是协助医生一起去完成这个介入治疗。我们和法国的一家公司在合作，正在开展中国的一个注册，应该很快在明年，快的话就在今年可能就会拿到注册证。还有我们的神经这块业务，神经的话，我们更多的还是对于神经系统这些血管一些疾病，我们也有业务布局。下一张。我们公司有20多年了，然后产品，因为我们是一个定位是一个国际化的公司，产品应该在100多个国家都有销售使用。下一张。好，稍微介绍一下我们公司的一个大概的一个研发的一个状况吧。我们的研发的投入还是蛮大的，就是这么多年，差不多20多年，应该基本上都是研发的投入占我们销售的20%甚至到30%，是稳定在20%以上吧。下一张。另外的话，我们公司是比较注重这个创新，包括就是注重这些专利吧。我们的就是研发人员占公司35%吧。另外的话，我们的相当于知识产权的工程师和我们研发人员的配比是6比1，就是6个工程师，研发工程师会配1个知识产权工程师。往下。这是我们的实验室，我们实验室的话也是逐步建立起来的，就是随着我们产品的这个研发的需要，因为我们的产品最早是直接在国内，然后应该是07年左右我们是走向国际，因为国际上的要求和中国当时的要求还是不一样的，要求是非常严格的，它是测试要从材料到后面的产品都会做一个严格的测试，所以这些也是我们逐步建立起来一套完整的测试体系。下一张。另外，我值得一提的就是我们比较重要的一个事儿，就是我们不光是做一些体外测试，我们会做动物这类的测试。这个测试的话，相当于这个实验室是我们自己建的，运行也有7、8年了。我们这个实验室的话， 不光是做我们自己，其实我们一些竞争对手也是在我们这来做，因为在中国这个动物实验室还是不是那么成熟，但是经过这么多年的话，可能也有几家吧，1、2家，那我们可以算是 top 1、top 2的这样的一个位置吧。然后我们这个动物实验室1年的话，可能现在啊，从小到老鼠到大到一头牛，这个动物实验我们都会做，大概1年没记错的话，1000多只这样的动物在我们这个动物实验室开展。好，下一张，这个我就不说了，这是一些材料方面的分析吧。下一张，知识产权刚才也说过了，我们现在目前可能拥有知识产权1000多篇吧，往下。然后当然我们会制定一些行业的标准，像世界上以前是没有风土器的标准，因为我们是先进风土器的第2大供应商，是全世界范围内，所以我们制定了这个先进风土器的一个标准，是国际标准。其他标准我也不一个个去说了，往下。我们的产品的话，就是大家做产品都知道，不管机器人啊，所有产品都一样，就是来自需求吧。我们的工程师每一年都会走向世界，参加各种会议，甚至到医生的医院去，和医生之间去合作去讨论，所以我们的很多的需求都是来自医生。说一下第一个就是 Lambro Left Arch Appendage Occluder 这个产品，是我们和我们的威尔士亲王医院的前内科主任林一贤教授合作开发的。等一下我会稍微再介绍一下这个产品。这个产品还是在全世界方面还是受到比较大的一个认可吧。往下，这个是我们的所有的目前在售的一些产品。这个可能就是一个代表，每个产品都是一个系列，可能不止这么多。我们往下吧。这个是未来，就说几年3到5年之内，也是有很多产品不断的在出来吧。往下，再往下。这个就是我们刚才说的，就是说我们几块业务，稍微详细的去说一下这个。我们这个叫先天性心脏病的分堵器，刚才也介绍了，它是把那个心脏上的缺口堵掉。我们这个技术已经发展了4代了，就是20多年，从原来的不可吸收了到现在的吸收的。最后一个那个 Absolute 这个品牌的系列的产品，它是可吸收的一个产品。就是之前是一个金属的，然后现在我们这个可吸收是一个聚乳酸的高分子材料的一个可吸收的封堵器。因为这个对于封堵器，对于这个先天性心脏病这个封堵器来讲，其实吸收和不可吸收这个就差别很大。这个病人都是对于非常小的小孩子，甚至几个月的小孩就要把我们的产品放进去治疗，而且这个产品是放在小孩的身体里面要终生的，所以这个吸收就非常重要，对这些小病人来讲。我们往下，这个就是我刚才说的和威尔士亲王医院林教授合作的这个产品，这个也是应该10几年前开发的，就是我们在做动物实验，包括设计迭代什么的。目前的话，这个产品已经在全世界范围内，就是可能现在就是除过美国，我们可能没有，就是说法规允许的这样的一个植入，其他地方基本上都是可以，就是合法的去使用我们这个产品，商业化的。目前的话，全世界范围内已经超过了2万例的一个植入，然后这个产品其实在这个领域里面的医生还是非常高的一个认可吧。往下，这个就是这个产品在各个国家的这些医生都是每一个地区或者国家的一个在这个领域的一个权威嘛，对我们产品就是说非常认可，然后他们也使用，他们去把我们的技术介绍到他们下面他们医院，包括他们国家的这些医院。值得一提的就是说，我们这个产品虽然没有进美国，但是这个产品的话，目前的话因为它有一些技术优势吧，所以美国的医生就是以医生的名义去发起了一个临床试验，有3000例的临床试验。在早期的话，我们也是想进美国，但是的话，这个临床试验确实是样本量很大，3000例可能需要6000万美金这样的一个费用非 非常高的一个费用。对我们来讲，对我们公司来讲，就是即使现在我们可能做起来也是有点费劲吧。我们是希望找到一些合作伙伴，但是合作伙伴可能因为各种原因，可能还一直没有找到合适的。但是刚刚这个比较好的是，医生认为我们的产品在美国，因为美国有一部分病人是用现用的产品是做不了的，所以美国医生就希望用我们的产品在美国去做这个临床试验。这个费用的话是美国的医保给报的，所以这个的话在这个算在这个领域里面也算是中国医疗界是第一次啊。往下，当然关于心脏的很多的疾病，除了先天性心脏病之外，还有瓣膜的疾病。瓣膜的话，我们有很多的一个布局。虽然我们可能相对一些国内在香港上市有好多国内的企业比较起名，可能大家都知道，港股上市的还是蛮出名的。但是我们稍微晚了，但是我们的布局还是比较全的。从那个瓣膜的置换到瓣膜的修复，所有的这个技术我们都有布局。最快的话，我们很快应该今年都会上临床试验吧。往下一张，再往下，这是我刚才说的，我们现有正在就是销售的另外一块业务，外周血管主动脉的这个疾病啊。这个的话，这里展示的这个的话还没有上市，在做临床试验，但是这个技术的话是在全球范围内应该没有几家在做类似的技术吧。或者是成熟产品是没有的，目前这个在全世界是空白的，等于说它是哪些病人呢？主动脉它会从心脏的刚刚出来那一段，大家可能知道的话，就是上面有3个分支，这个位置的话就是是非常难处理的。但是的话，对于主动脉的疾病的话，这里是70%病人在这里，它市场是最大的。但是目前因为它解剖结构复杂，然后技术难度比较高。没有合适的一个产品在做这样的治疗，那我们就可能有我们自己的新的一技术，烟囱技术，然后还有我们的叫就相当于这个叠加起来这个技术，相当于模块化的一个技术。这样的技术的话，我们是正在临床实验，很快也会面试的。下一个，这个就是展示了这个一些具体细节吧，就是稍微解释一下下面最上面这个图的话，等于说如果是要解决这样的一个3个通道都要供血，如果放一个支架的话，可能大家可以看到1和2这个位置的话，就是说我们拿其他的一些技术对比了，它就不会通畅，它会被压的瘪掉。那我们的技术就是它，当然我在这不详细说我们技术，就是它会达到这种它这个通道是通畅的。就保证这个供血是充分的，往下，然后这个也是全球范围内也是只有少有的几家在做，而且也没有成熟的产品。目前大家都是在做临床试验或者是肺母研究吧，这个技术也是非常复杂的，就是大家可以看一下这个本身产品看起来特别复杂，有很多的一个分支，要把这个相当于这个我们说的主动脉的，就中间这个粗的位置主动脉，那旁边有很多分支。如果说之前的话大家做的比较粗啊，我就把这个主动脉就保证的可以了。那这些分支也会供其他的脏器的一个就是其他脏器的供血。如果它堵了后，那可能其他脏器就会慢慢的会萎缩，或者是甚至于这个衰竭吧。那现在大家做的越来越仔细了，会把这些分支，但是都要保证它供血。但是如果要做成这样的话，真正产品在使用的时候，确实是有各种各样的一个困难和就是说技术方面的难点吧。那这个产品我们就已经设计已经定型，在临床试验了。好，往下，这个产品也是就基于和上面大家可以看一下和上面的类似的，但是这个分支会少一些。这个产品也是很创新的一个产品，这个产品已经上市了。往下，然后这是我们另外一个，就是说除了主动脉这个，我们是静脉的产品，就是腔静脉滤器。这个产品也是现在有3代产品，就是大家可以看这个结构，它是一个延续吧。目前在国内的市场还是就是 top 1%，50%到60%的一个占有率吧。往下，再往下。 这个就是我们未来基于一个铁基的可吸收这样的材料，未来可能发展的一些新的一些治疗产品吧。比如第一个，我们的叫冠脉的可吸收的冠脉支架，还有其他的，比如膝下的或者是肺窄的这些其实就是对于病人来讲，其实都是非常非常有意义的。因为大家现在就是除了就是之前的话，我们觉得我们可以放一个产品不可吸收的，我可以达到这个治疗效果。但现在的追求会更高的一个境界，就是植入，就是介入无植入，就未来就希望这个产品植入以后它会吸收掉，未来不会留的一个未来的一个因为毕竟放了异物，可能会对这个病人的医生的话可能有其他的风险吧。所以这个平台的话，可能我们也非常重视这个我们会把它现在是作为一个子公司在运行。基于这个平台会发展出来更多的一些业务吧。往下，再往下。当然，基于这个产品，我们会前面会参加过了很多的会议，也发了很多文章。再往下，再往下。这是刚才我说的和美敦力合作的。我们2012年美敦力就和我们的合作，在他们的技术、我们的品牌在中国推这个起搏器，现在已经销售有好多年了。往下。这是美敦力，他们基于他们的标准，在我们的先进的内部建的一个生产线。往下，再往下，就是未来我们扩展刚才呼吸领域，我们都有一个全面的布局。刚才讲了那么多疾病啊，我们都有布局。走得快的有一个肺气肿的产品，我们正在国内做大样本的临床试验。往下，这个是刚才讲的那个机器人，就是未来的话，当然现在在场的可能对机器人非常熟的，就是希望未来我们更多的交流吧。然后当然有更多的往下，再往下，这个我不就说了，反正社会上就是我们会经常会参加一些学术活动，然后推广我们这些技术吧。当然我们会从别人那个学到很多技术，互相融合。再往下，我们也会做一些捐助啦、筛查之类的。往下。就很高兴的告诉大家，我们这个公司20多年已经有100万例的这样的病人接受我们产品的治疗。这个也我们也觉得，就是作为先见的话，我们自己觉得还是非常高兴的一件事吧。希望未来的话，我们在我们的技术基础上和各位同行吧，就是结合我们机器人技术，能够把我们这些患者能够就是减轻他们的病痛吧。好，谢谢。
谢谢安妮。1 million patients, impressive. So our next speaker is from NVIDIA, Samuel Law, the general manager of NVIDIA Hong Kong.
Thank you. Good afternoon, everyone. First of all, I would like to thank Professor Liu his invitation for me to join this MedTech symposium today. Okay, before I jump into my presentation, maybe let me just introduce myself a bit. In fact, I run the NVIDIA AI Tech Center for Hong Kong and Macau. Okay, I formed this NVIDIA, our company, to form this tech center 5 years ago. And in fact, our office is in the Science Park 2, very close to everyone. We are in the building 12. Our key objective, okay, of the tech center, in fact, is to support a lot of the research collaboration with the university and also research institute like CAIR. We will have a lot of discussion later on, okay? So today, I believe a lot, of the previous speaker talk about, the industry, the surgical robot, the trend, the evolution. And my topic is more focused on, okay, how AI enable the field, our developers, okay, to develop their next generation medical devices, okay? So, next slide, please. So in fact, for those people who are not familiar with NVIDIA, yeah, definitely, we are a 30 years old company. We start with, design the semiconductor, business. But in fact, 10 years ago, NVIDIA also, start focus on building a lot of the ecosystem, the software stack, to support AI and HPC, as well as today very hot topics about the industrial metaverse. Okay, among most of this industry, healthcare and life science is definitely one of the very important industry that enable a lot of AI evolution. And this is some of the key area that NVIDIA is working on. Then you will ask, okay, why NVIDIA? You are just a semiconductor company. How is related to industry, like in the healthcare and life science? To share more about why we are in these pictures, because when 10 years ago AI is booming, a lot of researchers start using when you look at why AI is really booming in the market and get attention from the developers and researchers in different industry, because first of all, if you want to have AI enablement, you need huge amount of data, then you need the algorithm, and finally you also need the compute power, that is using kind of a GPU with the parallel processing power. With that angle, healthcare and life science definitely is the important pillar that can help or that leverage the AI capabilities. One of the reason why, because the world's largest data industry definitely is from healthcare and life science. That's around 30% of today's data is coming from the healthcare and life science, and we foresee that the compound growth rate to 2025 years is 36% growth. And among this healthcare and life science, we will see a lot of the pillar in this in the black circle, the medical devices, genomics, drug discovery, and smart hospital. And today we are more focused on the medical devices. And like I just mentioned, we design our GPU just for the compute, but we also develop a lot of the libraries, the SDK, and the application framework to help our developers, to focus on their medical devices development. Like in the middle layer, we have all this software stack, supporting our four pillar developers development. Like the hollow scan, later on I will spend more time how it can help our developer to develop more AI advanced medical devices using the hollow scan, with everything in real time. Every model you create can be seen immediately. I think that is most important for our surgical robotic development. And Monai and our friends from KCL is also a founder. Monai is in fact a medical imaging framework, open source, supporting the communities. I was told by our friends today is already have 1 million downloads for Monai. And in fact, NVIDIA is just part of it to empower Monai and provide the enterprise support to our developers, because as everybody knows, open source is good to use, but in some sense, if you are developers, you want to deploy in the enterprise and environment, in the production mode, you definitely, the community support is not enough. You need an enterprise support, you need a vendor support, so that you can get immediate fix for those, problem. That's why NVIDIA is one of the contributor and supporter for the Monai. And FLAIR is the fractal learning, because everybody know in the healthcare business, the privacy, the data privacy, the raw data is also one of the huge concern, especially in this area. So we also, support the FLAIR open domain in this healthcare environment. And Parabricks and BioNemo is another area just focused on drug genomics area. Okay, and the bottom side is what the full stack from NVIDIA provide. Later on, I will spend some more time on NVIDIA AI and the NVIDIA Omniverse. That is our digital twins we foresee in the future. Next slide, please. So when we look at, I believe some of the previous section already mentioned our surgery robot revolution, and now I would more focus on how the data, okay, I talk about, you know, in healthcare, data is huge, is tremendous, okay, and in real time. How you utilize those data, okay, definitely AI is one of the good platform to help analyze from two-dimensional data like X-ray, MRT, CT, and then, I mean, in the previous generation, we use this 2D data to form a 3D and 4-dimensional information so that you have more efficient or angle to look at, okay, some data in real time or in a very low latency. And then when it comes to the surgery robot, you come to the next level that is more demanding, okay, because what you're talking about is to navigate your robot in a more accurate location, right, in real time. That means very low latency. That's why, okay, this from 2D, 3D to 5D, that definitely you need a very good full stack, including the hardware and software to support our developers' development. Next slide, please. So this is some of the area we are working with our partners and developers, okay, to helping them do a lot of, you know, enable a lot of the AI algorithm to their existing robotic surgery, endoscopy, ultrasound, how to leverage those data input, and then we will have this real-time representation of the model so that when inside a surgery room, you can have more data that help you to more accurate to do your surgery. Next slide, please. And yeah, among, you know, those 2 million devices in the marketplace, among the 16,000 companies who work on that, and these are some of the modalities we foresee that can definitely need an AI enablement to support their ongoing development. And the application in the lower side, you can see that is the requirement. Okay, when they develop their next generation medical devices, that is something they need, and that is more AI can help, you know, from different angle. Okay, let's see from the streaming angle, that is for your inferencing, so that you can have real-time rendering, collecting your data so that the data latency between the raw device, the input device, to your processing machine, either on the edge or from an embedded devices into your medical devices, and that is something we foresee will be, you know, some requirement and component that can help our developers for the next generation AI enabled medical devices. Next slide, please. Okay, so this is some of the kind of the workflow to let everybody understand better by different layer. Okay, on the left-hand side, yeah, if you leverage the AI algorithm, definitely you need, okay, things, as I just said, from the training angle to train up your raw data to be a more accurate model. And then from on the right-hand side, you will be doing the inference. Okay, the inference, that means your medical device with the inference or edge capability to interpret what being formed from 2D, 3D, 4D, or 5D. And on the bottom side, that means the training always stay on either on the cloud or data center. And then on the inference side, you always use the edge device or your embedded device into your medical devices. Next slide, please. Okay, I won't spend more time here in some of the configuration and the stack. And this slide just show you, okay, if our developer need to develop well on those domain-specific surgery robot, this is something that NVIDIA can help, because on the left-hand side, most of the SDK here are open sources. That means those that can help our developers streamline your development. Your development will be more focused on your domain skills, focus on your surgery robot. You don't need to, spend a lot of time on how to, stream the data, how to form the 3D model, navigate the things. Those are handled by, this SDK. Next slide, please. Next slide, please. Yeah, okay, this is some of our, next-gen embedded edge devices support the development. Some can be embedded to the medical devices. Some you can add it as a clinical devices sit onto your next medical devices. It really depends. And it already built for the medical IEC 60601 standard. Yeah, next slide, please. Okay, this is some of the performance, and our sensors partner, you can see they already, leverage this technology to support, some of their AI-enabled medical devices. On the right-hand side, you can see the performance, on, the simultaneously supporting the video stream and also the model inference simultaneously. Next slide, please. Yeah, I mean, to our developer, definitely these are the four key requirements that help them on their development. Yeah, next slide. Okay, so this is some of our SDK support from input to output. So you can see the data flow and how it can be formed and trained and then inferenced to the edge. Next slide. Yeah, this is another example using the endoscopy and ultrasound samples data, okay? And on the right-hand side, you can also see the performance, okay, compared to the traditional methodology. Next slide. Okay, again, this is another comparison for the traditional endoscopy pipeline. As you can see, from in the past, from the camera, you can see from the display, it's always just a high definition 60 Hertz, and the latency is talking about 220 milliseconds. But with the new methodology and with AI enablement, and then you can have 4K 240 Hertz images, video in real time, and talking about 10 millisecond latency. Next slide. Okay, so these are our partners, okay, over 70 partners, well blended, already adopt this latest technology, full stack, to develop their medical devices. Next slide. Yeah, last but not the least, okay, so we hear about, okay, how AI can enable our developers for medical devices. What's next? I believe our previous speaker from Chinese U, Sam, also mentioned in the past, okay, they look at building up the prototype, okay, and then next 3 years they can see the result. But today, we can leverage the digital twins. The digital twins will be our next angle to see everything. If you start your prototype in the digital twins, that means it follows the real physics. Everything you build on it, you can measure from and simulate, okay, using the virtual world to conduct the entire workflow, like train up your robot, train up the entire workflow. Then you see the real outcome. And then if you think that the ROI is good enough, then you can build your physical devices or medical devices. So let's take a look at the video I prepared for you. How about the audio? Can you?
Accurate hospital environments, operating rooms, medical instruments, and even a patient's individual anatomy. Medical device developers can use these digital twins to create AI-enabled solutions. One use case is neurosurgery. During a procedure, a surgeon needs to manually reposition a robotic microscope to maintain focus on the region of interest and align it with their instruments. This prolongs the surgery and increases a patient's time under anesthesia. Let's see how this can be improved with an AI-based solution using a digital twin. We start with an NVIDIA IGX computer running the CAIR HoloScan SDK, which includes a pre-trained tool segmentation model. Real-time inferencing performance is validated with virtual scenes from Omniverse. In deployment, the IGX platform has been optimized for AI processing and visualization of high-bandwidth data streams. For example, 4K 60 FPS video is processed in less than 15 milliseconds. Without AI tracking, the microscope will not maintain alignment with the surgeon's tools. With tracking, the IGX platform automatically tracks the position of the surgical instruments and controls the real-time movements of the microscope. This can reduce the patient's time in the OR and improve surgical efficiency. The IGX platform is optimized for AI processing and visualization, even on high-bandwidth data streams. With IGX and CAIR HoloScan, you can build, test, and deploy, all on a single platform.
Perspective, I believe most of our developers can use this simulation to develop their future prototype before it, to get all this ROI analysis before it launched to the market. Thank you for the information. Bye.
Thank you, Sam, for bringing us into the future of the surgery.